Okay. Good morning, everyone. Thanks for having me here. First, I need to disclose my biases. My passion in life is cardiac surgery, and I'm an anesthesiologist. Some of my anesthesia colleagues probably will ambush me outside the building. I believe cardiac surgery is very innovative, and my passion in cardiac surgery is ECMO and MCS. I feel ECMO and MCS saves lives every day, highest level of technology. And I want to advance that more and more and see how we can help patients in a better way. I wish I had some financial relationship with Joe, but I don't. So every one of us goes to work every day to do our best. But we have some obstacles in front of us, and we're constrained by financial issues and like staffing issues. So we have to get around there. There's different ways of getting around there. We're going to talk about it. You guys feel the comments and tell me you're wrong or throw something at me. All of us, well, I guess not all of us remember, but maybe the phone was the biggest thing. And we're going a little about the call-in shows for medicine. When you called in, told the doctor how you feel, and the doctor on air told you what to do about it. So telemedicine started from back then. Yeah, it is a form of telemedicine. You have to remember, not everything was high tech like now. Now, you guys, this is your thing. And you know your thing better than anybody else. People see ECMO, they get scared. I think ECMO is the best thing. You understand the simple concepts. It saves people's lives. It has a cost to it, but it does save people's lives. I know a lot of people that are alive and walking today because of ECMO. And I know the numbers are very dismal outside, but I do believe in it. And we have to come up with ways of monitoring it. And I was telling Joe, and he didn't believe me, there's some places that, and I'm going to use some fictional names. None of the names are real. But there's some institutions and hospitals will mandate the perfusionist being there watching the ECMO 24/7. Is that feasible? Do we have somebody like that available every day? Joe, do you have somebody like that available every day?
We make it, but it's very hard.
And it's very costly to have something like that.
Yes.
Mm-hmm. Now, here, look at that. Look how amazing your setup is on the left, and all kinds of pumps and everything. And this, believe it or not, Joe came to my house. This is my setup for telemedicine. I'm a very simple person. I'm not that smart. 2 laptops, okay, and my workspace. As compared to this huge setup, look at the cost here versus the cost here. But you can use that cost on the right on the bottom to monitor the cost on the left in a very safe way. And we're going to talk about how to do that in a very simple, safe way and economic, using a board-certified attending to be your backup, to have any perfusionist call that attending for any help, and the attending will be able to arrange a team to go out to the hospital or arrange transferring the patient to a tertiary center. Again, I want you to look at the cost difference. Probably here's a couple of thousand, and on the left, probably 50, 60, 70,000, 80, something like that. Again, and there's more sophisticated ways. You can get your x-rays, you can get your echoes. So you can go from spending a couple of thousand, it depends how much money you want to spend, have a huge monitoring center. Now, huge hospitals, they have big innovative centers. So you can have a big center like that, where you're getting your x-rays, your echoes, your CAT scans, everything. And you can get the data from the ECMO. Now ECMO has wireless transmission. You can get the data right on your screen if you need to, instead of the nurse calling you. More, again, I'm just showing you different varieties. ECMOs, Impalas, transmitting to the monitors. So what's the advantage of the telehealth? Telehealth, you have a direct communication. The physician can look at what's going on in the room. So at this point in my little service, the nurse will call me simply, patient has a fever. I will do the fever workup, put the orders in my Epic. But if the patient is coding, I will turn on the camera in the room. The camera sweeps the whole room, see what's going on, stops the patient. I can see the patient, I can see the monitor. I run the code from my office, manage the situation, put the orders in. And it's live, and I communicate with the docs in the room and with the nurses directly. There's no in between. And the nurse can call me back. And if the patient is awake, obviously not a code situation, the patient can communicate with me. Patients love it. Some of the patients call it the eye in the sky. And I call it the drone in the sky. Now I think you can incorporate Tele-ICU with the shock centers. So let's say a big system like Methodist, which has peripheral Methodist, so that ICU center can serve to manage those patients. And if the patient needs to be transferred to main Methodist, that system can do that. Activate the MCS team, activate the surgeons, the cardiologists, get things going. So it can be your command center. So you can save money that way. Your referral center takes calls from whatever hospital it is outside and transfers the patient in. It can be simple, like this is here our very simple way that exists. I'm sure all of you see the commercials for telehealth, and you can the doctor comes in from his office, talks to the nurse, primary care, very simple primary care. It works, it saves money, it's very quick. This is the e-alert button for the coding situation. And it's all two-way videos. And the camera can be a fixed camera or a camera on a robot. Now here's a big sophisticated center. That's not like my little center. This is the high-tech centers where there are multiple monitors, multiple cameras, multiple beds, and you can do up to like 200-300 patients. You can put bags and bags in there. So big institutions can have huge centers, which have these big centers that can monitor, and you can have nurses and physicians monitoring. It depends on what kind of a model you want and how much money you want to spend for infrastructure. So every hospital, every institution can build it to its own way. And how is that going to work with the ECMO? I'll give you my thoughts in a little while. So what's the ICU center have? Board-certified intensivists that are available. Now I want you to know there's a shortage of board-certified intensivists. So you imagine all the, let's say Kinwood, let's say Magnolia, how many board-certified ICU attendings are available? Not that many. So if you put them in one place and you can communicate with them, it's going to be much better way, using your resources. You manage MCS, ECMO, sepsis bundles, vent management, early extubation, bleeding, anticoagulation, you name it. You can put whatever protocol you want in these systems. There's big academic centers who have major innovation centers. And what's good about the EICU? Although there are many attendings admitting patients to the ICU, the EICU unites the protocols. Then it follows the same algorithms. So there's uniformity. With uniformity there is success. I believe in innovation and uniformity. Uniformity is like when we walk at the OR and we say, are we doing this today a different way? No, we do the things the same way for a good outcome. Now, those days we don't have 24 cares now are gone. You need 24/7 care. If your mom is in the hospital, you want 24/7 care. If I'm in the hospital, I want 24/7 care. That day we don't have a day doc available. The doctor rounds, goes to the office, the pulmonologist. Those days are way gone. It's a big quality issue. Leapfrog reimbursement for the hospitals are getting for having 24/7 coverage intensivists. I mean, if you don't have 24/7, it's a big issue. And again, to have a 24 in-house coverage is impossible for some places, economically unfeasible. And so you have to substitute with telehealth. Now we're going to talk about multiple studies, and we're going to look at them on the slides with the safety and how things have evolved. Please stop for any questions. So what happens is there's models where the intensivist will round with the team, with the camera 24/7. Will come in the morning, round with the team, and the camera's following the team, and the team will talk to the camera, and they will just make changes. There's a pharmacist in the center. There's everybody in the center will have with you. The only things you need on the ground is PT and OT. In England, they're doing PT and OT telemedicine. I'm not sure how they're doing that, but they are doing it in England. Okay? So it's like a regular...
What's PT and OT?
Physical therapy. Yes. So doing physical occupational therapy. So the regular rounds, and You know, some hospitals are using different model where they have their own team during the day and they have a night team. The hospitals I'm covering right now, the day team was present on the ground. They will call me around. I'll run with them. A couple of hours later, I'll run with the nurses and the patients, as if it's like a regular day. I get to know my patients, and if there's any problems, I would just call the day team, ask them any questions. You get to know the doctors in the hospital. It's all about building relationships with people. And I see mortality reduction. We can show those numbers. We can see a lot of graphs later. I mean, there's no doubt having an intensivist available for the ICU patient reduces mortality. And let's say I will call you, tell you when your patient is bleeding or there's tamponade, and it will be an early call, and you know, get things going much earlier, because again, the nurse has access to call me. I can see, look at the room and look at the data and look at the patients. And you know, you can just like in any hospital, I'll ask anesthesia to come into the room and intubate the patient, put lines in whatever lines I need. So those kind of things people say, "Oh, how are you intubating through the camera?" Well, I'm not intubating through the camera, but in reality, all hospitals, they have anesthesia comes in to intubate. You get somebody put the lines, whether it's surgeons, whether ICU fellows are available, put the lines in. So again, you can go very sophisticated. This is a very sophisticated, expensive model, where the intensivist, advanced practice nurse, critical care nurse, and data analysis, obviously see how successful you are, and you know, IT, which is I cannot live without, because I'm not that smart. Here's a lot of data that can come in for you, and I'm sure it's a very busy slide. Let's give you a little information. And here's the most important thing for you guys to know. Look at the red parameters. You can set up the parameters any way you want to. So let's say on ECMO flow, you can set up whatever flow you want. If you do 1.4, do 1.3, or FIR2, you can set up whatever you want to, whatever saturation you desire. And to an alarm, you're going to go below the parameter and start flashing red. And that red alert, some centers have like, I mean, maybe I'm a little old, the blue light specials at Kmart. So there's some centers that when the red goes, you saw the blue light goes like in the whole room. Everybody knows there's something going wrong. So that's the e-care, that's the continuous monitoring care. So you set those parameters, whatever parameter you want. So for ECMO, I think you should have for whatever flow you want, okay, whatever FIR2 you want, whatever saturation you want, and you can have this flashing. If there's a problem, they will alert the perfusionist, and they will alert the doc what's going on. Again, very sophisticated centers. I mean, you change the protocols, and I believe you have to change the protocols working with the boots on the ground. I'm a big believer in the military. Boots on the ground are very important for you. You have to have a good relationship with them, and you cannot be fighting with them. You have to work together. And I will I will have my surgeons call me, tell me, what do we want to do today? And they will tell me, and we'll have a plan together. There's a problem, I'll call them. They have confidence that they come in, there's a problem, you come in, go to the R immediately. You have to be sure of your data, know what you're talking about, and see the patient and communicate with the people on the ground. It works out very, very smooth. In the beginning, there was a lot of doubts in the service. As I told you, I got that eye of the sky from one of the surgeons. That's why you the eye in the sky. And I wasn't offended by it. It's just I'm the drone in the sky. And now it's my new little line, you know. So every patient is going to be seen, because every room should have a camera, and then I mean that's the standards. You cannot say, well, okay, we can have it in one room and not in another room. For ECMO, I think it should be certain ECMO rooms they're gonna put the patients in, and they can put those cameras there. And it says like certain ECMO nurses are monitoring the ECMO in some hospitals. Those can communicate to the center, see what we can do about it. Like you want to change flows, you want to change FIO2. And I'm a little heavy on documentation. I will write a little note with every change I do. I think it does help a lot. This reduction in mortality, reduction, you can see all these graphs, and there's so many studies out there. This is a situation that had to be validated a lot. There's a lot of doubts in it, I'll tell you honestly. There's a lot of doubts that this is real. Reduction of length of stay, less sepsis, less pneumonia. I mean, just like any ICU that has a good team rounding on it. Less blood transfusions. I mean, we had like graphs of people transfusing at 9, people transfusing at 8, at 7, and we just we worked around with the docs. We see what the data is for that, and the reduction of blood transfusions. A lot of people, because they're not in the ICU, so just the safest thing for them from home. Hello, give blood, without any objective data.
Mm-hmm.
For me, I give blood depending on, I cover a hospital that has to get platelets from Philadelphia, and the hospital in New Jersey. So if I want to get platelets, I will start ordering it early, because I know there's a time lag. So you have to know these little things that make a big difference. Again, this did not happen overnight. It took years and a lot of communication. So you have to ask the system do whatever you want it to do. It's not going to do any more. So a perfect system will do what you want it to do. So when we talk about ECMO, I want to monitor the ECMO safely, and I want to have it safely and cost efficiently. Having a perfusionist bedside 24/7, and some hospitals mandate that 24/7 perfusionist bedside. Is that feasible? Is that economic? So you have to think: if I monitor remotely, is that going to work? Is that going to be safe for the patients? What interventions I can do remotely, or bedside I cannot do remotely? What kind of phone calls? What kind of access? I have access to a doctor in the hospital, to a surgeon at home, access to tertiary centers, access to other ECMO teams. Am I able to activate an ECMO dispatch team to go fix the problem much quicker than a perfusionist sitting bedside with no access to all this information? So I'm just gonna read it. Again, telemedicine started way back then. I don't know if people remember, and I give my wife a hard time when she tells me, look at this on the news. I said, am I gonna learn my medicine on the news? Am I gonna get the new innovations on TV or Facebook? So I'll tell you, I mean, telemedicine has been available for a long time. People called in, say, what should I do? I get frequent headaches. Or what should I do? I'm having chest pains. What should I do? That has been going on from the 40s and the 50s. So in technology, you have a bell curve. You have the innovators and the adopters in the beginning, and they help with early. There's the early majority of people. So innovators, adopters, then the early majority, and then the late people, half and half, and then the stragglers that I see that they don't care, or they feel technology kills patients. So accepting like something like that, Joe, maybe I'll let you comment on these slides. So the perception is that the doctor is the sky. The doctor doesn't know the patient. These perceptions we have to get over. And here's the acceptance slide with the numbers. And it goes from the younger residents to the older population. People in the beginning said telemedicine is going to kill patients. Now it's like people feel that they needed to improve quality. And there's a little resistance, and I have to tell you, I'm going to see biased. I might get beaten up when I leave here. The nurses in the units felt that having a model like that would reduce nurses staffing at bedside. There's some conflict, and I was talking about that earlier. People on camera will argue with people in the room, and I have to tell you, you have to get over that. We're all working together. Collaboration is the key word. And there's some centers that the programs got shut down because people were fighting on camera. That's inappropriate and it should not happen. As a courtesy, I'm an anesthesiologist. If somebody's intubating on camera, I will always shut the camera off as a courtesy. And then I tell the nurse, call me when the procedure has been done. And I believe that 100%. You're putting lines or put a camera, you're intubating, just shut the camera off and then resume, because there's nothing you're gonna do on camera that the person on the field is not doing. So I do feel you have to have some courtesy. And collaboration is the key word. So I feel like you always have to visit the hospital that you're covering. They have to see who you are, like that you really exist, you're alive. You're not a voice in a box. And work with them, meet with them, see what they want to do, how they want to innovate, what do we want to do together, what kind of meds do we need, what kind of protocols do we need, what's our objectives. We have to have one plan. Having multiple plans and fighting with a bedside team is not good for anyone. You have to also arrange lectures and teleconferences for those nurses and bedside teams. And I even sometimes when taking lectures, I see slides and I send them to the ICU charge nurse. And she appreciates that. She'll tell me, I feel like we're with you in the lecture. And so maybe management of bleeding, just a few highlights that you feel that you're thinking about them. And I'll tell them, I went to this lecture today, this is what I thought about you guys. Well, maybe that will help. You have to keep that in mind always. It's part of your daily work. And a lot of people in the beginning, were not used to having a tele-ICU. So really, you have ICU staff that works in the bedside and what does tele-ICU. You have some who don't, and you have to have a medical director that sets up the standards. I feel a medical director is very important. Set up the protocols and standards. More important, the medical director works out of collaboration. The medical director should sit with all chairs from every department, see what their objective is, and how can we get it done together. You are a deal maker. You're making the whole system work together. You're not isolated at home or in the sky. I keep saying the drone in the sky because I just saw the drone delivering organs on LinkedIn. This is going to say a new thing now.
Oh, wow.
I've seen that.
Yeah, I'm telling you.
They have drones delivering organs.
I was texting Scott. I told him, Scott, Chan, then we're going to have to stand outside to drop the heart and wait for you to catch it.
What's better than me walking 2 miles down Fannin Street to Children's in the middle of the night?
Or getting to the helicopter to get to the airport, to fly someplace, to fly back.
That's crazy.
And why do I mention that the drone delivering organs came? What did they learn from? They learned from Amazon. So we all learn from technology and innovate together. Amazon does package deliveries with the drones. For in our house, the drones will be hitting each other because I know how my wife shops in Amazon. The drones will be like colliding with each other. I think I'm not gonna have a ride home. I think one of you guys have to drop me off. So really, we learn technology from there, and you have to just innovate. Cardiac surgeons taught me. Trust everything, check everyone. Okay? I learned that. Data is very important. These are studies looked at the mix of medical ICUs, surgical ICUs. Some of you guys might disagree with me. I think the easiest ICU to be covered by tele-ICU is the cardiac surgery ICUs. Why? Because you have swans, you have output, you have index,
data.
You have invasive, a lot of data. See, like just data. You see this data, so you have the nurse telling you data, you have the monitor telling you data, you work it all together. I can look at the echo, I showed you before, I can look at the X-ray, I can look at the CAT scan. I have all the data available for me right there. And this is what I need. And just put it all together, see whatever questions I have, and call the bedside team. You can put lab alerts, you can put hemoglobin alerts for ECMO. If hemoglobin drops to 6, that will alarm that you need to intervene. So again, you're not keep checking the lab and refreshing. All of us have done that. Refresh Epic, refresh Cerna. So that's, if you have the hemoglobin set up at 7.6 and just have it alarm for you, it will just give you the alarm then. So you're proactively intervening. there's no question there was a reduction in ICU mortality. And overall hospital mortality, ICU length of stay, because why the patients are being managed actively at night. It's not like, oh, just let them rest tonight, we'll deal with it in the morning. Some people call me and say, should they worry about it in the morning? I said, is this a 24/7 hospital? And I'm sure you've heard that before. I said, no, I want to, let's just take care of what we need to take care of. High compliance with best practices. I'm going to use one example for myself. I tell the nurses, do not call me a patient. You don't think they're breathing, don't call me. The first phone call should be to anesthesia first. You're empowered. You don't think a patient is breathing, do not call me. Call anesthesia first and intubate. Then call me and see what's happening. Because why? I want to err on the side of caution. There's nothing I'm going to tell you, oh, patient's not breathing, let's just try. No, I want the patient to be safe. This is the kind of standards you have to have. 24/7 coverage for something like that. You have to have seasoned attendings. And I have said, and again, a lot of people might kill me outside. Feel ICU telemedicine is for seasoned attendings because you have to have seen what happened multiple times and able to make decisions on your own. And really with the feedback of data and your patient and your nurses. So you have to empower people, and that's bedside teams, they appreciate it. The nurses appreciate so much, I will never counter. They intubated the patient, go ahead, intubate the patient, secure the airway, oxygenate the patient, don't waste any time. And I would never be mad at them for doing the right thing. You have to always reward people doing the right thing. When you come around in the morning, you want people to do the right thing for your patients.
Absolutely.
Exactly, that's it.
Because there's hell to pay when they don't.
And I'll tell you something, you do the right thing. I mean, it sounds so simple, do the right thing, nobody gets in trouble. And the patients do very well. Again, there's a lot of multi-center trials, 56 ICUs, 32 hospitals, different health system, from small, and that's the thing is you have to look at small health system, big health system, and length of stay reduction, ICU, length of stay, hospital length of stay. At the same time, I have to tell you something. When doctor calls me, I want to put the patient in the ICU, is that okay with you? My answer is always yes. Why? This doctor is calling me, they're in the line for help. My answer should be always yes. I'm able to see and monitor this patient and see a lot of data, but he cannot see. And he's calling me for help. So my answer is yes, put the patient in the ICU. If the patient is doing very well in the morning, we'll downgrade, send them out again. But there should not be a discussion, yes or no. It should be yes, let me bring the patient, let me take care of him. And if everything is good and perfect, they can go out in the morning.
Right.
A few hours in the ICU for the patient's safety is very important.
Well, that kind of goes to the implementation of rapid responses versus waiting for code blues. Empowering the nurses to feel comfortable calling the intermediate team before the code team to come up and look at them. Mortalities go down significantly when you empower the nurses to do that, and that's essentially, this is the next step in that.
Absolutely. And I'll tell the nurses, do not hesitate to call me. I told them, you over-call me, don't under-call me. And, do the right thing. I mean, I've never been mad at them for intubation. I told them I can extubate somebody very easily. You intubate inappropriately, or like the patient is going to do, I can extubate them. No problem.
Right.
But do the right thing. Intervene quickly and call me. And that's why having a 24...
Well, again, that's the anesthesiologist in you, too, who's seen airways all day, every day for however many years versus strictly pulmonary critical care as well. So your point on getting anesthesia involved that's the way I deal with it. If there's any question, I just get them to intubate and clean up the mess in the morning, because airways usually where you're going to get in trouble.
Absolutely. Brain oxygen, if you don't save the brain, nothing else should be is going to be saved. We let patients go because they don't have any mental status, right? That's the reason most patients they let go.
Right.
But if you save the brain, everything else will be okay. And again, you have to empower the nurse, like I call. You cannot be yelling, oh, well, I'm not there. But if they feel that patient needs to be intubated, it's okay. And I just make sure you call the expert, which is anesthesia at my point, and come, intubate, secure the airway, and I can always extubate in the morning, it's no problem. Yeah. Err on the side of caution. So the EICU will see with the patient, and I can look at all the labs, I can look at the CAT scan, X-ray, everything in a few minutes, and look at the patient. I don't have to travel or go anywhere. And I'll tell you, that's very important. And I'll tell the nurse, can you go into the room? Our camera in right now. I can talk to the nurse, I can talk to the patient. And it's really, I mean, the patients love it. They feel there's a doc there that's, at the beginning, the patient's going to doubt it. Or it's the voice of God. You know, and sometimes I can joke with the patients. I mean, yes, it's the voice of God. So you need to rest. We'll take care of you. You'll be okay. The patients have confidence. There's a doc available to them.
I would think too the staff would, like it as well. I mean, because I was reading the other day that Cleveland Clinic did a study and they reduced the number of pages as well as calls by about 60% at night. So, there's a lot of burnout, right?
Absolutely.
With critical care staff, et cetera. And so I would think that the nurses and the staff would appreciate having someone monitoring 24/7 so they're not called continuously throughout the night.
I'll tell you, they appreciate it a lot. Right now, I mean, and the nurses I've been working with, really, I have to tell you, we have like a relationship. Although we're far away from each other, we do have a relationship. We try to make them feel like they're part of everything, and we get to know each other very well. Preferences, they know me very well. Like I'm an overgiver of mag. I will give mag liberally.
Me too.
Yeah, you see. So they know that Samir
It's
mag.
3. We're still in AFib.
Exactly.
I give some more.
Give some more. And I correct acidosis aggressively because you guys taught me to correct acidosis aggressively. See, from being on the heart-lung machine, we correct acidosis aggressively. And I correct acidosis. They know now that they have to have a box of bicarb available. With Dr. Samir's on, box of bicarb stacked up. Mm-hmm. And the codes, they run it with high-dose epi. I never give 1 and 2 milligrams.
Yeah.
I give 5, 10, and some codes 100. So there's a nursing supervisor that tells me, Dr. Samir, when I know you're on call, I'll go to the corner of the room and start loading the app if there's a code. And they get to know you, get you to know your preferences. It works out very well. The team on the day.
And a lot of times, sorry to interrupt, but it's they know what to do, but they need that order. And if you're available, it's just,
Absolutely.
it moves quicker versus waiting for the guy that's been up all weekend to answer a page, and then they start paging another doctor, and then it's that happens as well. And sometimes those minutes are precious.
Absolutely. And, they just want, like you said, they want the order and the support.
Right.
And I'll tell them, they know Samir's on, and I'll tell them, how I run the codes. And they were already loading up the app before they call me. They know we're going to give 10 milligrams at a time, Mm-hmm. And the charge nurse said, Samir, when the hospital's loading up on bicarb when they know you're on. And, and then the day team gets to know who you are. So sometimes the day team tells me, Dr. Samir, can you be on call when we're working daytime because we have a very good relationship, sign out. I know they know what I will need to know and just work it together. And we get to the point you have to know the tertiary center which you're going to send to patients because some of these hospitals are very small and you're going to send to a transfer center in Penn. I get to know all the surgeons in Penn now.
Right.
And the PE team and the heart failure team in Penn.
Right. And when the smaller hospitals are wanting to transfer, it's just they don't know anybody a lot of the times. And if you can make that easier for them, they love that.
Absolutely. It's all about building connections and respecting each other.
And that's a good point. I mean, when you're doing the Tele-ICU monitoring, is it mainly in urban settings or rural settings?
Right now I'm covering, believe it or not, beach setting. I'm going to make you laugh. It's a beach setting. It's a hospital. We're right on the beach. That's covered part of the shore in Jersey. And right now it's beyond busy. See, hospitals here are not that busy in the summer, but that hospital is crazy busy in the summer. Because that area gets highly inhabited, mm-hmm. And and I know people come in, and I know what's coming. A lot of sepsis, a lot of dehydration, a lot of HOH abuse, a lot of MIs, and I see it gets really, really very busy, and I see it all the time because I don't travel in the summer. I love Houston heat. Put me in the pool in the Houston heat, I'm good.
Gotcha.
So I'll tell you, that. But there's now healthcare systems. Academic centers, and these studies are based on academic center. That integrate their smaller centers together. In New York, the biggest center was Westchester County Medical Center, with all the little hospitals through the system, and they all feeding into it. And there's some health systems where it's a company monitoring a few hospitals, that unrelated to each other. But the ones that have health systems, let's say Methodist system and Herman system, we monitor the ones that send central commands. Okay, And really, there's no suburban, but I mean, they found that it does help academic for the residents burnout, who the residents are on call. Well, especially with the centers when you have, I want to activate heart failure and shock teams. So you're right now, like I want to take in and activate my heart failure team, activate my shock team, activate your perfusion team. So it works out that integration that way. You make the best use of your command center. You built it anyway. You spend a lot of money in it. You can use it for e-care, and you can use it to get your shock system built. Your referrals in, instead of having the transfer center. And the transfer center is relying on phone calls and beds. You know which bed the patient should go to. CCU, MICU, surgical ICU. It's your decision. And people on the ground, we work with them, where the patient should go. Am I taking too long, Joe?
No, you're fine.
Okay.
You're great.
You have to work with the ICU committees, and see what you would like, and see if there's something you see what's missing, and send them your recommendation. Communicate with them. That's what you think should happen, and back and forth. And there has to be an ICU committee on the ground. So I asked my charge nurse to be on that ICU committee. She liked it a lot. Jen and I, we communicate with each other a lot, and now she takes my request to the ICU committee. It works out very well. So all of us are in charge of quality. All of us want the best care for our patients. I say nobody's waking up in the morning to go to the hospital. Oh, I want my patients to die today. Everybody wants their patients to do very well today. So I always have I take a point when people say, well, I'm here to make my patients safe. Everybody wakes up in the morning, gets in their car to go to work, to keep their patients safe. So the ventilator rounds were very important, and whether you're going to use the data of 7 cc's per kilo. Like I changed that for cardiac surgery. When it was the cardiac surgery patients, I would go up a little in the 7 cc per kilo. I have the RT call me with the ABGs directly. I mean, I don't put it as just, if there's a problem, call me directly. Don't wait to call, it's an epic, just call me. Tell me, tell me what we can do together. So we do that, we can do vent changes, get patients extubated much quicker. Yeah, and here again, I see mortality ratio decline. You can see the graph. It's very clear with vent management. Dr. Scarlock, which is the publisher of this study, is one of my mentors. He's an amazing guy, and he knows about Tele-ICU more than anybody else I know. And again, so that's something that we were talking about smaller hospitals. So they take the robot, they run with them in the big hospitals on the ventilators, and see what the vents are, what's the settings. Should we get a patient spontaneous breathing trial, and see what happens. They cannot breathe, put them back on the vent on the regular settings. Mm-hmm. See, I have two choices. I don't know a third one. Either you can breathe or you cannot breathe. Mm-hmm. I'm sure you're the same. I can tell. I don't have something in the middle. You can breathe or you cannot breathe. If you can breathe, we'll take the tube out. If you cannot, it's okay. You have to always look for the safest thing. Low tidal volume is very important because it decreases lung injury, 7 cc per kilo. But again, you have to tailor to the kind of patient, the kind of surgery the patient had. And the patient habitus, which we know in Texas, the patient habitus is very small.
Right.
Extremely small.
And just real quickly, when you do have a large patient like that, and they're having trouble getting the parameters they want to extubate, when you see a patient and they're lying totally flat, does that kind of ring a bell? Like, hey, maybe we need to get them a little more in Fowler position to help with their tidal volumes and numbers? Because in ECMOs, you'll go in and sometimes they're totally flat. You're not getting the numbers you want, and put them in 20 degrees, and next thing you know, voila, lung compliance is better. All the numbers just get better.
I always tell the staff when they do that, would you like to lay comfortable in bed flat like that?
Right.
And I'll just imagine yourself. The best person with the staff people, that would you like to be uncomfortable like that? Just like the people say, well, no coffee, nothing after cardiac surgery. So if you take my coffee away, it would be a hostage situation.
Exactly.
You'd have to use the SWAT team outside, you know. If they don't have my coffee in the morning,
Right.
why are you depriving the poor patient? What did the patient do to you? I mean,
Heart surgery is not a contraindication for coffee, so
exactly.
yeah.
It's the same thing. Set up like sitting up thing with the balloon. Don't sit up with the balloon. The balloons get dislodged. Oh my God, it's gonna migrate. I mean, if it's gonna migrate, it's gonna migrate.
Right.
I mean, that's not really gonna be. You have to do the right thing and the safest thing for the patient.
Right.
And be comfortable, because if the patient is gonna be comfortable, they're gonna cooperate much more.
Mm-hmm.
I'll tell you, after cardiac surgery, I mean, maybe I'm bad. Have you ever listened to bowel sounds?
No.
No. For me, if you can take PO, you know, I let a couple of sips of coffee ginger ale. And if you aspirate on that, then you're going to stop. Nobody has died from a couple of sips of coffee without milk, like black coffee or
Right.
diet ginger ale. But you're making the patient's life much better. Because my wife will tell you take from me my soda and my coffee is going to be a hostage situation. You get much better compliance with the patients. They will do pretty much whatever you want, you know. I mean, they tell me, we're keeping the patient MPO. MPO for what? I mean, take your pills PO instead of giving IV meds. I mean, nothing better than get your meds PO, get everything PO. The patients are happy. The mouth is not dry, and you know, and you're reducing the cost. That's another thing about reducing the cost. When you take PO cost of meds is much lower than IV meds.
Right.
Less nursing cost, less everything cost. So you have to. So that's part of the global thinking of the ICU team. You have to think like really outside the box. And you know, and you have to look what's the worst thing is going to happen is I tell the nurse, if you aspirate a couple of drops of black coffee, it's okay, just stop. But you have to get swallow a vial and do all that. No, just after something, you have to either die, you know, drink or not drink. As simple as that.
Right.
Okay. Now, legal issues, which a lot of people at the beginning were scared about, and we're going to go into that. And please feel free to be controversial. Okay, so obviously, one of the most important things people don't realize, you have to have a license in the practicing state. So, like, I'm covering a hospital in New Jersey, I have a New Jersey license. It does not matter if I have a Texas license, because I'm not operating on my house. You have to worry. A lot of people get confused about that. It's the destination state where you have to have a license there. You have to have your malpractice and everything there. Just as if you're in a regular hospital. You're a regular hospital out of your center or out of your house. And you have to have privileges and a license and malpractice, everything like anything regular.
Do you pay taxes there?
No. Thank God I pay taxes.
Because, you know, like professional players, you know, when they play like in New York, they pay state, city, and federal income taxes.
You know,
they got all these crazy returns, but
I moved out to New York for a reason, for the cold weather and the taxes. I'm not going to go back to that. Okay?
Right. Okay.
No. You pay regular taxes here, all that, but you have to have your New Jersey license, your New Jersey DAA.
Maybe I shouldn't have brought it up. So they maybe they'll start looking into taxes.
Yes.
Cut that part of that comment.
Okay. And, you know, again, you have to build really relationships with the boots on the ground and respect them, because they are really part of you and you're part of them. The other day, I wasn't feeling well, and the nurse said, we're very worried about you. Don't say you're coughing a little, we're very worried about you. That makes you feel like you really you're part of, they say, we don't see you, but you're part of us. And that really was like something, for me, very amazing. I felt like, you know, we are one team. And I always tell them, if you want to call me at night time, then like somebody else is covering, there's an issue, just call me. Again, you have to make it easy for them. You know, whenever they need something, they call you, regardless of what they need. You tell me if I'm too much on time.
You're doing fine.
So have you ever looked at what your effect is? Are you basically like now 3 or 4 or 5 pulmonary intensivists working a 12-hour shift? By the way, have you looked at that? What does your time put in actually translate into, as far as one guy that rounds every day in the unit and then rounds in the afternoon and then goes home? I mean, are you essentially acting as 5 pulmonologists?
Well, I'll tell you, we looked into it. I mean,
Because that would be very interesting from a cost and resource standpoint. Obviously, the resources are limited, and so this helps that. But it seems to me that it would help the cost as well.
Well, I'll tell you what a hospital right now has. One of the hospitals that I cover is they eliminated their MPs in the ICU at night time. So they only have attendings during the day. They have attending and us at night time. So they have no. So that right now it's Me and the nurses. The hospitals only will come to
saving time and money.
Yeah, they're saving them, exactly. The hospitals will come to only, I will need the hospitals to pronounce the patient, because legally you cannot pronounce the patient, you know. So the hospitals, they do the admissions from the ER. I got to the point also that I requested that the ER attending, if they have a question, instead of fighting with the ER, there's a lot of always controversy with the ER, like, just call me. If you have any question, call me. That day, the ER attending intubated the patient, and they couldn't ventilate the patient. And he's panicking, told him, try 100 of rock. He said, are you sure? Told him, I'm sure, it'll be fine. If there's a problem, just blame me. Told him, I'll just take the responsibility.
Yeah.
They give the rock, it doesn't mean no problem. Ventilated the patient, no problem at all. And that's the thing, is you have developed those relationships, and it helps and reduce the controversy. So right now, the hospital has no MPs in that. You know, there's a huge cost saving right now. And having one attending, and our model for this specific hospital, for a couple of other hospitals, is one attending per hospital nighttime. That attending is dedicated to that hospital, okay? Knows all the patients, only for that hospital. And really, it works out. Believe it or not, the cost in the end is much less than having an attending as an MP at night over there.
And CMS, they're realizing it as well. They're increasing reimbursement.
Absolutely.
Yeah, so they're going to be, they're going to scrub it down and make sure that they're not spending more money. Otherwise, they wouldn't increase the reimbursement. Correct?
Absolutely. And I think you need to expand this wisely but efficiently. So I think you look at telemedicine, and that's why I would like to bring it to perfusion, the ECMO story for sure.
Right.
Because I see it all the time. I see my poor perfusionists, like they're stressed out nighttime and stretched out. Daytime, they cannot cover the wars, and they're tired and exhausted. Just you cannot function like that. You get a little center which covers a few ECMO beds, and then you have a bill for a doc. Then you tell me, doc, we need to get this patient out of another hospital. I get this transfer going. I know which ambulance company in Houston can handle transferring an ECMO patient there. Yeah. And the one that has, I'm sure you guys know, has a bus basically that converts, they can take the patients there.
Right.
And you have the relationship with whoever surgeons or cardiologists in your tertiary center to get things going. And you accept, you don't want to get to the point that somebody's calling you, oh, the flow is 0.5. Should we transfer the patient? No, don't, because the flow 0.5, that's no flow. That's just the machine churning. So, I mean, you want to get to, because if you transfer early, there might be, this is a very high risk situation. You transfer early, there might be some hope. Mm-hmm. You wait late and wait and wait and wait till the liver fails.
Too late.
Then forget it. When that's the thing. When you start to see liver enzymes going up, it's way too late.
You know what's going on. Yeah.
Exactly. When you're not draining the heart properly and you see pulmonary edema frothing out the tube, then it's way too late.
Too late.
I mean, and this requires expertise. People thinking, why should we put like a drainage or impala, whatever you want to put drainage with an ECMO? Because you need to. That's why we see the lungs tearing apart and pulmonary edema spewing out. You really have to use technology for the safety of the patients. And I'll tell you, I mean, I'm not gonna lie. In the beginning, I wasn't a big believer, but Dr. Skerlock convinced me, and he be nice to your fellows. I did. He was one of my fellows in Methodist, and he moved and started telemedicine in New York, and he's amazing and innovative at it. Published unbelievable studies. And I'll tell you, I learned from him a lot, and I now, if I have any question about telemedicine, I'll give him a call. And it evolved. He had it evolved in the consultation service. There's the e-care manager, which is all the analytics, and that I feel the e-care takes away from the relationship with the boots on the ground team. Because the e-care is alarming for you all the data. And sometimes you're just calling the people, tell them what to do. I'm not sure they like that much. But for the consultation model, that the nurses call and they know what your ways are and they help to manage the patients. Just like I think right away, when somebody's calling me, like they call me in my call room, what I would do, so just manage the ABGs, manage the vent that way. Little things make a big difference in the morning to get the patients out.
All right.
The most big malpractice concern, we're going to get sued right and left, nobody's seeing the patients. The drama, I call it the hopla, the drama. Oh, we're going to get sued, lawsuits, nobody's seeing the patients, the camera, the eye, the sky thing. And the sarcasm, you get a lot of sarcasm. And I got used to the sarcasm, and I answer sometimes. I learned from a lot of very bad people I work with, from some gangsters. I'm sure you know them, Joe. I'm sure you guys know all of them. Those gangsters, those gangsters taught me the kind of responses I should give. So again, do docs do bedside orders? They do. They do phone orders. There's a lot of student phone orders. Did that increase lawsuits? Okay, and they looked from that. They went from look at Tele-ICU. Tele-ICU getting live data. You look at the patient directly. You're implementing bundles that have been proven to work. You know, you are in the work environment right there, seeing what's happening. You're not in your car. You're not in McDonald's line, putting your order for a Big Mac, and taking a call from the nurse. You're not in a party. And I have to say it, having a little drink and looking at the camera. You are right there, look at the camera's going on. So, I mean, so if you don't think that's safe, you tell me what's safe. And here's the data for all the malpractice claims. I mean, the data speaks for itself. I'm not going to say anything. And has there been an increase? Has there been a drop? You look at it. And you can tell, having, again, like you said, intensives available all the time is the board certified intensives all the time. I mean, for sure, that has been proven over and over that reduces costs, will reduce claims. Malpractice, absolutely. You're not getting an exhausted resident, an exhausted doc goes with his patients in the office all day, you know. And you're able to make available resources for that team that they need. You need a general surgeon, your lactate is very high, your belly is distended, call the general surgeon. And you give them data, objective data. Most of the time they speak to an attending, most of the time they'll come in with no issue.
Yeah, that's the thing as a surgeon. You just want the data.
That's it. You want objective data that you can depend on.
Right, and a good general surgeon, cardiovascular surgeon can take those things over the phone and make the diagnosis and know that they need to come in. I mean, I couldn't tell you how many times just with numbers that I've come in and it's been the right decision because like you referred back to as far as the cardiovascular ICU being the easiest, there's just so much data. Even if you're not experienced, the data points you almost infallibly to the problem, or at least to you need to open the chest up and figure out what's going on, or you need to open the belly up and figure out what's going on. I mean, there's, for the chest, tension pneumothorax, tamponade, things of that nature, they all require a surgical intervention. They're all pretty much the same to some degree. You can do all of them very quickly. Absolutely. But they have a very finite number of parameters that if you ignore, the patient's dead. If you don't ignore, you can save a life.
I thought you had a situation the other day in one of the small hospitals that did not have a vascular attack on call. And the nurse called me, the patient's having pain. We think it might be the neuropathy. I turned the camera on, patient is screaming in pain. I know very well that screaming in pain is never a neuropathy.
It's ischemic pain. It's the worst pain ever.
It's the worst pain ever. The patient is like jumping off the bed from pain. I thought there's no way that's neuropathy. They were going down the neuropathy pathway with Neurontin and all that. So we need a stat duplex. We can't, there's no tech available, all that. Lucky again, there was an amazing supervisor that I know very well. She was on call. She said, calling them, Samir, I'm going to make it happen. And she called people at home, people not on call. One of the techs giving, God bless his heart, it was a vascular occlusion. Mm-hmm. And then he thrombectomy. And what did that lead to? The next day, they changed the policy of the hospital as having a vascular tech on call. So that's a positive impact. Again, it's not just about torturing people. So do the right thing. It's right. And again, it's a diagnosis. Yes, the patient has a very bad neuropathy, but you just said it. Vascular occlusion, patients jump off the bed. It's the worst pain. And so when you hear it once in your life, you never forget it. So it all depends on your experience that you heard that before, seen that before. And just you keep insisting again. Just get that. And people appreciate it. And the nurses and the patient appreciate that you did the right thing for them. Not blow it off or think, just give some more morphine. Give some more morphine. Mm-hmm. And that would be an easy call over the phone. But you don't know the patient. You're not seeing the patient on camera. But seeing the patient jump off the bed is you'll know.
Well, the flip side of that is maybe somebody who's hypersensitive to an ischemic limb and worried about not calling somebody, having the camera. If the patient's sitting there, my leg really hurts, and they're not. And I've had 2 morphine, and I just can't stand the pain, but they're talking to you like this, you know that's not,
Scary.
that can wait till the morning. And the other, my classic question I have for anybody ever get a phone call, can they dorsiflex their foot? And if you can see that, I mean, oh yeah, they're doing their feet like that, and maybe it is cooler and whiter and pale and looks ischemic. It's chronic ischemia. That can wait. I've got a lady in the hospital right now I'm dealing with. She's just, it's uncomfortable, but it's not ischemic pain. And so.
Acute ischemic pain.
Correct.
Yeah.
And everybody was freaking out about it, but if you have a camera you can lay on, that you don't have to go in the middle of the night, or you feel comfortable letting that patient go to the morning.
Absolutely,
and
and you can talk to the nurse and talk to the patient.
Right.
And I talk to the patient. Is to talk to the patient. Talk to the patient. How is your life? It's the worst pain ever. I haven't had pain before. She has neuropathy as a chronic condition, so she knows her neuropathy pain. The one thing I will just hate to diverse is about ECMO. The big, I call the anticoagulation shenanigan. Everybody has their own thoughts. The patient start, and I'm sure you agree with that.
Yes.
So we try to have uniformity for something like that, and have a doc available for you and just have the same standard. Be amazing. Especially if you have your lucky day, a patient has a hit, and you're on something like Angiomax or Gatrobang, and there's a little careful management, or you need to replace antithrombin 3, wherever, and people are just running away, going up and up on the heparin and doing some, you know what I'm saying?
Right.
Mm-hmm.
So really this kind of dramas where you got a lot of phone calls and that can impact hugely because you keep anticoagulating and eventually they're going to be hosing out of that. So
Yes, I will.
that's the kind of positive impact I would talk about. Mm-hmm. I mean, it's really little interventions that help that situation. You're going to tell me, Joe, if we're running out of time, right?
Yes. Let's see. Is that your next slide? Yep.
Yes. And I would like to adopt that you don't know what you don't see, but what can I say?
Well,
I don't want to.
that says Edwards Deming, but you don't know what you don't know. Now, I have to stop you here. And I've said very little, but if you remember, it was Don Rumsfeld who said there are things we know, things we know we don't know, but there are also those things we don't know. Those are the unknowns. Yes. So you credit Deming with that, but I'm going to credit Rumsfeld.
No, this is way before Rumsfeld, though.
You know,
I don't know that I credit Rumsfeld too much on that.
So I would like, for me, I'm a visual person. I see something, I can see what's happening. I kind of get an idea what's going on. Once you see an ECMO patient hosing from every ECMO hole, you don't forget it. And then you know that's going up. Those days of giving 25,000 units. It was a couple of years back, I went to the ER. They want to put an ECMO on a patient. They're getting ready. And they start taking the patient, see blood is shooting out everywhere. Now, how much heparin did you give? Oh, we give 50,000. So are we going on bypass right now? Yes. Because we're not going on full bypass.
Right.
I'm sure you've seen that.
Yes.
Right. So they say,
then they stroke, and
exactly.
It's all horrible.
Exactly. So why would you do this? Well, that's how. Is this the standard when you're in the OR? I said, yes, that's the standard. If we're gonna go on full bypass, that's not what we're doing. You know, and that's understanding that if you're running high flows, you don't have to anticoagulate heavily. If the patient's see this kind of things, it needs you have a perfusion central command with an attending backup for you for any situation like that. And that's my thought about how you can integrate telemedicine with ECMO. Okay, the whole misdiagnosis story. Okay, I don't want to get in trouble, but I have a little comment about the bottom picture. Maybe you can call your physician is indisposed or exposed, whatever way it is. Okay, and then is the police coming to get me, Joe?
Yes.
Okay, I can tell.
Make it silent. Phone silent.
Yes. He's texting me to tell me to put my phone on silent.
Okay. So again, misdiagnosis. I mean, all the issues with misdiagnosis and medical errors. On Wall Street, and it's been like harping on that, how much it costs and all that. Again, look how much data you're getting here. Except waking the guy in the middle of the night, he hasn't slept in 2-3 days, and you give him data, he's not sure what it even means. He's not looking what you're seeing. He cannot look at data. He cannot look at X-rays, CAT scans. He cannot talk to the patient. So it does make a big difference.
Quality of life and less burnout
Absolutely.
for the intensivist, as well as the staff.
Oh, and just personally, what I get is we use encrypted text messaging, Telegram, basically. And so when they give me a report at night, before I go to bed, or when they think I'm about to go to bed, they'll just, even if nothing's wrong, they'll send me just snapshots of the monitors and all the labs. And then if there's anything that happens in the middle of the night, or they get concerned, they do the same thing. Because you can literally look at all those data on your phone and make a decision based on that. Because I still swan everybody. I mean, and the reason is, well, the patient was a single vessel off pump and blah blah blah. It was super easy to do, no problem. But those are the ones that you got to get out of the hospital. Those have to do well. And if you don't have, and yes, there are potential complications with every time you stick a person or use some invasive monitoring device. However, if you do those procedures all the time, that frequency is almost negligible of complications. And you also have the great benefit of having the information readily available to make a good decision, even if you are tired. Because I have it on the phone, and that's my version of telemedicine, I guess. When
I agree. Maybe we are not crazy. I believe in swanning all these patients.
I do too, and that just it's a standard at our hospital in the Woodlands. And some other surgeons that come that don't necessarily do that, anesthesia drives that, and they don't have a choice because they're in-house and they're, maybe managing those patients if they can't get a hold of that guy. So they're using that information. So we don't give any of the surgeons a choice. That's our protocol. So,
I'll do that.
And I don't consider it overkill at all.
No, I'm a heavy user of swans, heavy user of echo. I like it.
Oh yeah, we'll take a TEE over there and drop it in at the drop of a hat.
Absolutely. I don't want to guess. I'm not a good guess. Otherwise, I'll be in Vegas.
Right.
I mean, I don't want to guess. I want to see. I want to see what's going on.
Yeah.
I get the echo. So, like any of these patients that come into the ICU, I don't know their hearts. I don't want to get a cardiology consult. I just need data to get an echo in the morning. I just want to see what's going on with the patient's heart.
Mm-hmm. I can literally at 3 a.m. get a CRNA to go drop in an echo, and I can look at it while they're doing it by FaceTime.
I'll tell you, really, having echo and data is very important. And for echo patients, you can see there's tamponades going on affecting your flow. You're not flowing like you used to flow. Right. What's going on? Yeah, it's chattering. Is the patient bleeding around the heart? What's going on? So I feel getting data is very important. Mm-hmm. And getting echoes are very important.
Yep. That's why every heart patient should get a TEE during the surgery for that reason, to manage them, but also to keep your team facile in how to put it in and run the machine. I mean, all of our CRNAs, we have half a dozen CRNAs to different levels of expertise, but they can all put it in and then all turn the knobs on and they can all move it around to where you can guide them in seeing what you're looking at, and combine that with your objective data from the SWAN, the arterial line, et cetera. You can make good decisions.
I'll tell you, really, you can never have too much data. You have to have data and know what to do about it.
Right. Well, that's
data for the sake of data.
People say SWAN kills people. It's not SWAN that kills people. The SWAN is not attacking you.
Right.
It's your bad interpretation of the data is killing you.
Right.
And killing your patients.
Yep, you got to trust it.
Absolutely.
Dr. Samir, you brought up cost a minute ago. Are a lot of these hospitals reluctant in, putting up the capital to build the infrastructure and cameras, et cetera, around the ICU beds? I mean, because it's $50,000 to $100,000, isn't it, to equip?
So that's what I talked to Joe before about this. The cameras, it's a heavy cost in the beginning. The camera cost in the beginning is about per bed is about $10,000.
Okay.
About $10,000 per bed. And then you have to have the cost of obviously the monitoring of the situation. And you're going to go with the e-care system, the continuous data monitoring, or the consult system. Depends what you have, what you like. In the beginning, if you're really not, I recommend to go with the consult system in the beginning, because see how it works out. And you feel like you need the e-care. The e-care is a little a lot higher cost, because you're getting all kinds of data.
Yeah, but then you don't get that interaction like
Exactly.
Yeah.
I like the interaction, and him and I agree on that. I like turning the camera on and talking to the patient. I like the nurse being able to call me directly. And with the e-care, you are going to have less interaction with the staff.
Well, hospitals are embracing it. I mean, CMS published some data, I think in 2014, to where in 2002, there were only like 16, and correct me if you will, 16 hospitals that had adopted Tele-ICU monitoring. And then in 2010, there was like 213. So more and more hospitals are embracing this technology and incurring the cost, the capital, to set up the infrastructure to have it. So
Absolutely. And if you set it up like and add to it like a lot of services that have the hospital, like teleneurology, you're gonna get the neurologist available to see the scans like right away. How many peripheral hospitals have access to a neurologist and neurosurgeon to see what's going on?
Not many.
Not many. And so you combine that with another service that works out very well. And I think you look at the cost of your staffing 24/7, which is something Leapfrog mandates to have ICU standards. Like, would you operate for a cardiac surgery hospital? Doesn't have an ICU attending to see your patient?
Mm-hmm.
No. And that's the thing that is it for the safety of his patients and for.
But that went on for years, of course, you know that. But I think what I'm seeing is, if I may, is that this technology is allowing for a much higher level of care and types of services in terms of specialties that ordinarily don't exist in those facilities. So you're able to bring far greater level of expertise to a hospital that doesn't have that as a service at all. I think that's the benefit, or one of them.
And that's why I asked, where are you spending the majority of your time? In suburban settings, or because I would think that's where the greatest need would be.
But I really want to get to the point that let's say big systems in their smaller hospitals. I mean, you've gone through this. They want to put an ECMO. Oh, how are we going to put an ECMO? We have nobody to take care of the ECMO.
Right.
Or we should have a perfusionist 24/7.
Right.
No, I want to get to the point that yes, we can put an ECMO, but somebody's taking to take care of the patient for us. We can take this kind of patient. We can take a high-risk cardiac surgery patient. We're able to do ECMO backup. We can do a high-risk PCI, available with Impala, available to us, because there's somebody got to take care of this patient post-op. Right. So you're basically expanding your service, and that's how the reimbursement increase. You're pushing the procedures because you're able to have somebody take care of this patient post-op.
Yeah, I think a nurse, since we're talking about ECMO, I don't think an ECMO specialist, except in unique circumstances where they're working in a big hospital where they have a lot of patients and they see a lot all of the time. Let's just take that out of the equation. I think that, because those are unique. I think, however, the average, well-trained, critical care level, registered nurse in an ICU, similar to a hospital at, say, St. Luke's the Woodlands, Memorial the Woodlands, Conroe Regional, wherever, is more than capable of, with some direction from someone who is responsible, whether it be a teleperfusionist or whatever, turn a dial until the number reads what you want it to read, reducing the flow to 3, increasing the flow to 5, turning the sweep from 4 to 6, and then rechecking the gas, following the circuit or adding fluid because it's chattering and recognizing what that is and being able to do those things. Do I think they should have access to the negative side of the pump to do a rapid transfusion? No. I think that's way too unsafe and risky. But do I think they should change the oxygenator? No, I don't think they should. But can they recognize, and can the teleperfusionist recognize in advance that, hey, this is trending this direction because you're watching it, and then get the clinician on their way to then work with the nurse, change the unit out, or do whatever else needs to be done from a more aggressive intervention that might need to happen. And that one person can be managing several areas of a city that's on the ground, the boot on the ground, versus the one person in a tele-monitoring system that could be watching 3, 4, 5, 6 ECMOs at one time. So you're basically
Right.
you're basically improving the resource utilization formula and tilting it towards adding higher level of service to more hospitals.
Cost effectively.
Cost effectively, yes. Thank you for adding that.
With a high level of expertise behind it. So cost efficient, high level of expertise. What would you want more than that? Cost efficiency level of that is a very important formula that should always be people remember that.
Right. And there are hospitals, you know, I don't mean to, please forgive me, but there's many hospitals currently that do not provide ECMO as a therapeutic option because they do not have anyone who can monitor it without shutting their open heart surgery program down.
Right.
And patients that show up there, if they cannot get them moved quickly and they become too unstable to move, languish, and probably don't make it when there's a very good chance they could have. So I think this is a social a social issue that we have. We're not taking care of patients the way we should be able to in many hospitals that simply do not have the resources to monitor these devices. That's what I believe.
I agree 100%. And I mean, the whole thing is, and I hate to say this, and correct me if I'm wrong, a good surgeon, any good surgeon can put an ECMO circuit in. And then what happens after that? That's the question is.
Well, I was about to bring that point up. That the easy part is putting it in.
Putting them on. That's real easy.
We actually piloted a ER ECMO placement of witness arrests on the northwest side of town, and learned a lot. But we were teaching emergency room physicians and cardiologists and pulmonary critical care, and they're putting it in. I mean, we had the little guy in the closet, the ECMO system in the closet, the cannulas. They're putting them on FEM, VA ECMO, and then once they got them to where they were semi-stabilized or completely stabilized, we took them over to the unit and did what we needed to do. They got a heart cath. They changed out for bigger cannulas, different sites, et cetera. And we had some great saves from that.
Well, the lady, the I forgot her name now. The woman whose husband died. She was her sister.
Well, can't use her name because she was a patient.
That's right.
As
her
well.
sister, right? That's
no,
true.
her husband died.
Her husband died. Her sister worked in the unit,
right?
And she
witnessed them doing CPR on him.
Yeah, and
she got Takasobos, and she went down, and they put her on VA ECMO there, and she walked out of the hospital.
A year later, she at the New Orleans conference danced on the stage with
otherwise she'd been dead.
That's right.
If that happened in any other hospital,
gone. Yeah. That didn't have that ability to immediately initiate ECMO. That's right. Mm-hmm. Okay.
See,
please.
And that's without the heart surgeons there. Heart surgeons, I mean, that was that Desai put it in, or
that's right.
The ED doctor.
Yes. Yes.
You've seen patients being ventilated like to death before they get transferred to another hospital. If you exactly. Early placement is they succeed much better. They do much better.
And it doesn't even have to be the Avalon if they're not comfortable with it. They can just put 2 peripheral venous cannulas in, and put one higher than the other, and anybody can. If you can put
a Quentin in,
yes, you can put that in. Exactly. Very good point.
And see, and that's the thing is, you really early placement. That's all with the critical care team. Get the patient out, transfer early. Don't hold on to the patient.
And also to possibly, by looking at this over the screen, you can say this is not a viable candidate. We should not do treatment by ECMO. I mean, there's no reason to do it because this patient will not make it no matter what we do.
Yeah, that's got to be central ECMO, and that's just.
And that's the thing is, you're right. I mean, ECMO success depends on candidate selection. Right. And if you choose the wrong candidate, you have to be the right candidate at the right place, right management. So a lot of things.
You can be called by an ED doc, say that's the only way this guy's going to make it is with ECMO, but you can get the information to go, he's not going to make it even if you do put him on ECMO.
Exactly.
So don't do it.
Very good point. You have two columns and a dividing line smack in the middle that can move left or right. You have every patient on the left side who they're going to make it, whether you put them on ECMO or not, they're going to make it. Then you have the ones over here that aren't going to make it no matter what you do.
Mm-hmm.
But then you've got that middle,
Yeah.
and that middle moves. And it's
Right.
the patients who, well, they might make it without ECMO, but it's going to be real tough. And
Well, that's why I liken it to the intubation analogy. That's
you can. Yes, it's invasive, but you can always take it out.
But you have a limited amount of time.
Correct.
And if you waste that time,
Yes.
you miss your window of opportunity. That's why I'm just like Dr. Samir. If you think about it, you probably need to intubate them. If you think of ECMO, you probably need to do it.
Yes.
And sometimes they get blinders on, and I'll get this call from the pulmonologist, and then I'll say, well, what's their diagnosis? Why are they in ARDS? Oh, they have pulmonary alveolar hemorrhage. So I'm like, so you got blood coming out of the
stage
ET
4
tube
cancer.
and this, and they're like, I was like, we got to put these people on heparin, right? And now if they're young, there's again, it's still a decision to make.
Sure.
But if they're 80 and have that, that's a non-survivable situation.
Right, but that has always been the criticism, and I think that's going away. It's improved significantly, but it used to be that people believed if you put a patient on ECMO and they survived, they did not need ECMO. And then other people believed that
if you
for
the balloon pump.
Correct. And if you put patients on ECMO and they didn't make it, ECMO doesn't save anybody.
The innovators, the early adopters, the
late
adopters and the laggards.
And the laggards, exactly.
And that's exactly what it is. You got to, one of the innovators, who I know a lot of people question was Bud Frazier.
Yes. And they still,
we were putting ECMO in people.
Check my phone. I'm sorry.
We were putting people on ECMO left and right when I was a resident, and everybody's just talking in the background. But you know what? I firmly believe he's one of the reasons why it is where it is.
I think you need to be innovative, and yes, you're gonna make some mistakes in the beginning, but you need to be innovative to help people. And you just everybody's coming to work in the morning wants to do the best for the patients. And if sometimes you're not sure the technology is not gonna work or not, I would say go ahead and put it in. If you don't think it's gonna work, always take it out. Mm-hmm. Stop ECMO. Say take like the VADs.
Yeah, stop.
Like people. We ask you to put a VAD, but then the family decides on hospice later and turn the VAD off. That's okay.
Right.
Are we good?
I think so. Yes, kind of. Go ahead. Next. Let's just keep going. Oh, you have a slide up there. It's not on. Oh, it's right there. It's right there. Keep going. One more. Yeah.
So a lot of patients, they believe they want to see a second opinion, see another doctor to help them with their situation. A lot of doctors are resistant to that. Having the EICU doctor available that they can talk to, it makes them feel comfortable that there's another opinion, in the situation. You look at the CAT scan a different way, look at the X-ray in a different way.
That's pretty remarkable. Pathology, second opinions are that different.
It's amazing. It's amazing. I'll tell you what I really learned that this is a big difference when it comes to lung pathology. Lung pathology is crazy different, and and right now I'm suspicious of a CAT scan. I get a high-res CT, and a lot of people don't realize that there's a big difference when you get a high-res CT than regular CT. What's going on? And then talk about ECMO now. Now you have to be able to do a lung biopsy on that patient. And how many times a lung biopsy goes bad, you need an ECMO support. Mm-hmm. So you really have to, when you're going to do a lung biopsy, in the back of your mind, have an ECMO circuit available. And again, that takes readiness and experience with having this over and over and over. Not be scared. It's okay. We can put the patient on ECMO. It's a couple of days. I've experienced this before. Mm-hmm. Lung biopsy, put the patient on ECMO. For some reason, there's our lung transplant physician. He's an amazing guy. And he says, we do not know why patients deteriorate after lung biopsy. We have no idea why, but we're not going to ponder it. We're just going to take care of the patient. And and then 2-3 days, he's an amazing guy. And Dr. Wong, he said, just just like we do not know why they deteriorate after a long biopsy. Just put the ECMO and move on.
Yes, that intellectual curiosity that sometimes gets our patients in trouble.
Absolutely, absolutely.
When one thing can fix multiple different diagnoses, just it's like pericardial effusions. The patients are like, well, what caused it? I don't know, but this is how you fix it.
Exactly. And you're going to feel much better. And once they feel much better, say, I'm great, I'm very thankful and appreciative. And there's a lot of patients that want a second opinion. Don't underestimate that. And a lot of doctors get offended when you have a second opinion. Nothing wrong with getting a second opinion. And I'll tell you, I'm a critical care physician, and I believe in the patients. We have to do the best thing for them. But the last statement, I'm heavy into it. And I wasn't before. I learned getting a palliative care consult on all these patients. Just give them the options in life. The palliative care guys are much better than me in explaining the choices for terminal patients. Much better than me. They give them different choices. And they'll call me on the phone, tell me, well, that's what we think. And I'll tell you, get an ethics or multiple palliative care, nothing wrong with that. They're much better than me. And I'll tell you, it becomes a mandatory consult for us right now. To have had any patient is to get a palliative care consult. Mm-hmm. And that really, and the patients are much happier with that. They feel informed, they know their choices.
Well, and they're included in the decision.
Exactly. And here's some financial stuff, the money stuff. Here's the look at 7 ICUs, 2 campuses, 830 board beds, academic medical center. I'm a little biased. I know what that medical center is. Different kinds of cases. That medical center is in a weird area. It's on a cusp of 2 counties. One is a very rich county, and one is a medium-rich county. And it's very weird, like the kind of patients they see. And it's supposed to be the trauma county also of the hospital. It's a county center. I can tell you as much. But they do private heart surgery big time. So they looked at the case mix, they looked at the, how much they're getting for every case, how much they're saving, length of stay, and the initial capital investment. Which is the biggest deal, the initial wiring. That's the biggest capital investment. The patient would divide into 3 groups. A group with Tele-ICU support, a group without, and a group with the Tele-ICU support, with a logistics center, with like an e-analytics. That logistics center was the first innovative idea of having a center that can manage the patients and manage the transfers. And really, any hospital, academic center, to make that investment in a center, should use it for both. That makes sense to me. Okay, it's just use it for your ICU care and as your transfer center. You have somebody you're paying 24/7 anyway, and you have them. Then they know critical care and they know where the best place for the hospital the patient should go. What else beats that? It's better than calling the nursing supervisor and waiting for whatever bed is available. Is it the CCU, MICU, Neuro ICU? Like, controversy. A vat with a bleed. Where are we going to put them in Neuro ICU? Should put them in the cardiac surgery ICU. And like I'm a biased person. Put them in the cardiac surgery ICU. Have neurosurgery staff look at the patient, because you have to look at the best person managing the patient is the cardiac surgeons or the cardiac surgery ICU attendings. Neurosurgery is best at dealing with the head situation, which needs to be taken care of, but also they need to take care of the whole body. We sometimes forget about that. And that, like a logistics center, can manage all kinds of studies, can manage a lot of things. I think really take advantage of a logistics center. A lot of people, unfortunately, are not doing that. Now, the telemedicine pharmacist, I'm not that smart in choosing antibiotics and interactions. My PharmDs, they're amazing at it. I will always leave these things to the PharmDs. Antibiotics, drug interaction, PharmDs are amazing at it. And again, this whole, we talked about the admission request, medical patients versus surgical patients. Where should they go? That's the discussion all the time. Should we put them, where should we board them? And here's the cost. I'll let you look at the slide. And just the abbreviations I had to learn. The critical care and then major critical care. Whatever that means. Okay? And documentation and over. And as all of you know, the reimbursement for ECMO was good. Then went down, then it's back again.
Right.
Yes,
Yes.
they reversed
They reversed it.
they reversed it completely.
Exactly.
Went right back to the way it used to be.
Exactly.
And I don't mean to continue to interrupt this thing, but there was so much controversy around that. Now I don't know this 100%, so I'm going to make make the disclosure that I am not 100% certain of this. However, I keep hearing on the word on the street was that one of the temporary VAD companies was going to CMS and influencing, which CMS is wrong to have done that, but influencing this decision. Have you heard anything about this? Do you know what I'm talking about?
No, to be honest.
Okay, good. So we'll just leave it at that. But the big companies, LivaNova, Medtronic, all of the big ECMO companies, Getting, ELSO, and STS, all went to CMS and said, you've got to reverse this. This is not appropriate at all. And that's what resulted in the reversal. Thank God, because it was a nightmare.
Absolutely.
$8,000 to do a VV ECMO. Can you imagine? That doesn't even pay the cost of
equipment,
of cannulation.
Yeah. So I just want to show you one thing. The reduction in length of stay, groups without Tele-ICU, 10.4 days. Remember, they mix all the patients together. Groups with Tele-ICU support, 9.7 days. Groups Tele-ICU support and logistics center, 8.8 days. The logistics center also can help place patients in LTACs. Again, find an LTAC that takes a vent, a trach, and a dialysis. That's a major dilemma in any place. So you have to know what your LTACs where you go to.
Well, and you get them to the right ICU, just like you said before.
That's
so
right.
versus coming into the medical ICU and then, well, this is more surgical, or this needs to be this, and then transfer them to another place. So
and then let the
makes
teams
sense.
run around behind the patient. Oh,
Right.
He's in medical today, he's surgical tomorrow, and keep moving the patients. I mean, it's inappropriate, to be honest with you. This is the cost adjustment and documentation. I'll tell you, maybe I over document, but see, my laptop is next to my camera laptop. While I'm looking at the camera, I'm just documenting on the side. Here's the financial outcomes. I'll let you look at it. That's really important because, again, whereas technology and saving patients, we have the reality of Obamacare, Trump care. Who care after that? Not sure. I love that slide because you can tell I'm a proponent of the logistics center. I'm a big proponent of it. You're moving patients out quickly, putting them in the right place. You're doing the right thing, putting them in the right resources. For sure, it's going to save money. There's no way you think it's not going to save money. You're using length of stay, getting the patient out. You can take more patients in. You can do more cases. You have less CMS issues, less cases with sepsis, less cases with pneumonia, less, skin breakdown, less DVTs. Just do things the same way every day. Uniformity is very important. I think you should innovate and be uniform. That's very important. That balance is very important. And having protocols helps you to be uniform. And then also, but you're able to innovate.
Just don't kind of an aside for that regarding the best practice adherence. Do you have like a checklist of the core measures? You go over every patient when you're making rounds to make sure that they got like SCDs and DVT prophylaxis. I mean, I mean, it's probably just become second nature to you, but is that something they report back to you every day, that and the usage of Foley's and central lines and all that stuff? Are you in charge of that on the rounds?
Yeah. Absolutely. Absolutely. How long before should we take it out, or should we leave it, should we put it there? But I'll tell you, but sometimes I go the way that sometimes, infection control doesn't agree with me. This patient needs a Foley, put it in and leave it in. I'd rather a patient piece of Foley than having skin breakdown from urinating.
Absolutely.
And
or if you're worried about the renal function,
Exactly.
monitoring that.
Exactly. So, I mean, sometimes the infection control look at the angle. You're not going to have, UTIs, but they're not looking at skin breakdown. So you have to look at the whole, globally, the whole picture. That's the thing. I'd rather patient has a Foley, maybe I take a risk UTI than have a skin breakdown. If you've seen a bad skin breakdown, you'll never forget it. When you see bone that you can, I have one of the nurses, she says that, unfortunately, little joke, Dr. Samir, I can hide my fist into the wound. And when you see something like that, and I'm sure you have, you'll never forget it.
Right.
And the patients die from that.
Well, that's also looking at the patient. Are they ambulatory? They're able to get up? Is this person wheelchair bound when they came in? I mean,
Lucid.
I know. Yeah. Well, and we have on our Epic generated orders reasons for keeping a Foley in, and so at least we do agree with in our hospital system with the infectious disease people. We have reasons for it, so they don't ever bother us as long as you document it.
That's it. That's what I always say. The patients are going to fall off the track, and you just have to document where they're falling off the track. Like you're not going to use 70 cc's per kilo for ventilation. They call them off the track patients. Huge patients, huge belly, and you really need a big tidal volumes. You just have to document it. Why are you going to fall off the track? Again, I'm going to remind you again, that picture is very important. Everybody just look at it and understand. You guys are much smarter than me. The complexity of what you do is on the left. So you try to combine the complexity of what you're doing and what I'm trying to manage. And again, it's my little setup. And as like I said, my one laptop is for the camera, another laptop for documentation. And my brain. I could not put my brain in the picture. Anyway, and that's the thing is you're trying to coordinate that effort, what's happening at the bedside. You don't have to have a bulky situation like you're having at the bedside. So you talk about cost, here's the cost. On the left is thousands and thousands. And you guys know that. And on the right is just a simple setup. It's the consult service, which I believe people should start with that like that. I mean, the consult service, get to know the people on the ground. If you want to expand to the e-care system, you think you can do that, you can afford doing that, then you should. But I do prefer the consult service. You get to know the staff, you get to know everyone, and you get to be involved with the care. And I think it helps the relationship become stronger. You can transition to e-care as you expand more. So I think you should start slow. That's my little opinion. And again, the initial investment is going to be only the camera and the 2 laptops for attending. So you have the cameras, 2 laptops for attending, and you have to pay the staff, obviously. That's it. So you have staff costs. The hardware cost is not that much because you have and then the camera. That's a fixed cost nobody can change, unfortunately. And unfortunately, like I was saying before, it's one camera company that produces the camera. Nice investment they made. This is a little live action, which is very. That was not like a code or anything. Yeah.
You want me to start the video?
Yes.
Start the video, please.
It's just a simple situation. Are we able to?
Are we all okay? Are we okay?
Obviously, you cannot hear the stuff from the other side. It's coming into my earphones.
Okay, I would give him a liter of LR now, okay? A liter of LR. Okay, please, yeah.
This was patient who was
okay, thank you.
vomiting for 2
so
weeks.
we're going to be giving him a lot of boluses tonight, okay?
And
whenever his pressure drops like that, give him a liter, okay?
Just keep going fluids. That's it.
Yeah. The treating numbers.
Exactly.
The real number you got to treat is what.
Let me know if hemoglobin less than 8, okay?
And just I give them parameters and just keep
going. Hemoglobin less than 8.
That's it.
Okay? Thank you.
You don't have to keep guessing. I go give hemoglobin less than 8. We're gonna give multiple. It's very simple. Those are the code again. It's simple consultation. So I just want to tell you how it works. That's it. So I want to thank a few gangsters I worked with that taught me a lot about MCS and ECMO, and they're true gangsters. Now they're dispersed all over the country, and really they're all very good friends. I enjoy hanging out with them. They taught me everything I know about MCS and ECMO, and I owe them a lot. I want to help teach them a little about telemedicine. I'm good.